I want to tell you about the moment Arthur's wife decided she was going to call me. It was not a dramatic moment. There was no fall, no emergency, no ambulance in the driveway. It was a Tuesday afternoon in their kitchen. Arthur was trying to carry a bag of groceries from the counter to the table, maybe 15 feet, and he had to stop halfway. Not because of his heart, not because of pain. He stopped because his legs felt uncertain underneath him, and he did not trust them with the weight. Arthur is 71 years old. He has walked 3 miles every morning for 2 decades. He has a posture that belongs to a man who means it. He had never, in the 38 years his wife had known him, hesitated to carry a bag of groceries. She did not say anything to him that afternoon, but she called my office the next morning. When Arthur sat across from me, he told me what he had told himself for the better part of a year, that he was 71, that this was what 71 felt like. That his father had been slower at 65, so he was actually doing well. I asked him 3 questions. Was the weakness gradual, or had there been a specific moment it started? Gradual, he said. 18 months, maybe 2 years. Had he noticed it most in his legs, or everywhere? Mostly his legs, and his grip. His handshake felt weaker to him. Had anyone looked at his medication list in the context of his muscle function? He looked at me the way people look when they are not sure what the question means. Nobody had. I am Dr. Amelia Carter. I have spent the last 20 years in cardiovascular medicine, and I have sat across from variations of Arthur more times than I can count. People who are doing everything right. People who are walking, eating reasonably, going to their appointments, taking their medications exactly as prescribed, and people who are getting weaker in a way that nobody has named for them. Today, I am going to name it. There are 7 categories of commonly prescribed medications that have documented, peer-reviewed, clinically established evidence that they reduce muscle mass, impair the processes your body uses to build and maintain muscle, or accelerate the loss of strength that can make the difference between independence and dependency in your 70s. 7 medications, taken by tens of millions of seniors, almost never discussed in the context of muscle. I am not going to name them yet. Not because I want to hold anything back unnecessarily, but because if I list them now, many of you will check whether yours is on the list, find it there, and spend the rest of this video trying to decide whether to stop it. And stopping some of these medications without medical guidance is genuinely dangerous. What I want you to have instead is the complete picture, the mechanism, the signal your body sends when a medication is the driver, the tests that can confirm it, and the specific, non-confrontational language that turns this from a suspicion you carry alone into a clinical conversation that changes your management. Stay with me. All of that is here. Before I walk you through the 7 medications, I need to give you a framework that makes everything that follows make sense. Because muscle loss after 60 is real and it is common, and some of it is genuinely age-related. The question I want you to leave this video able to answer is a more specific one. Is your muscle loss happening at the rate it should be, or is something accelerating it? The clinical term for age-related muscle loss is sarcopenia, and the baseline trajectory looks like this. After the age of 50, adults lose on average 1 to 2% of their muscle mass per year. That sounds like a small number until you do the arithmetic. Over 10 years, that is 10 to 20% of the muscle tissue that carries you through your day. Over 20 years, it is the difference between a person who is independent and active at 75 and a person who requires assistance for ordinary tasks. That baseline trajectory is real. It is physiological, and it can be meaningfully slowed with the right interventions. But there is a second trajectory, a faster one that does not come from aging, but from the pharmacological environment inside your body, from the medications that interact with the molecular machinery your muscle cells use to survive, repair, and grow. And here is the clinical reality that very few appointments have time to communicate. The clinical reality, muscle protein synthesis. The process your body uses to build and maintain muscle tissue can be directly suppressed by medications, not as an unusual side effect. as a documented pharmacological consequence of how certain classes of drugs work at the molecular level. When that suppression is operating alongside normal age-related muscle loss, the combined rate of decline is not additive, it is multiplicative. The body that should be losing 1 to 2% per year loses significantly more. And because the decline is slow enough to feel like aging, it is almost never identified as medication-related until the damage is substantial. And Arthur was not unusual in how this happened to him. Arthur was typical. Typical in that the medications were appropriate for the conditions they were treating, typical in that nobody prescribing them had done anything wrong, typical in that the conversation about what those medications do to muscle over months and years simply does not fit inside a standard appointment, and typical in that the gap between what the research shows and what reaches the patient is the gap this channel exists to close. There are 3 types of people watching this right now. The first type has noticed progressive weakness in the legs, in the grip, in the ease of ordinary physical tasks, and has been told it is age. You have accepted that explanation even though something about it has always felt incomplete. This video is going to give you a more specific frame to bring back. The second type is on multiple medications and has not made this connection. Some of you are on 2 or 3 of the 7 categories simultaneously. The combined effect is something no single prescriber has modeled for you because no single prescriber sees your full picture. Pay particular attention to the overlap section. The third type is watching this for someone else. A parent whose strength has declined. A spouse who has become careful in a way that worries you. You may not be able to make the appointment happen, but after this video, you will know exactly what to say to the person who can. Number 4 on this list is the medication that surprises almost everyone, including physicians who have prescribed it for years. It is not a heart medication. It is not a blood pressure medication. It has nothing to do with the cardiovascular system, and yet it is actively destroying the nutritional foundation that muscle depends on in a very large number of seniors who have no idea. I am going to get there, but I need you to understand the mechanism first. Before I give you the 7, I want to give you the framework that applies to every one of them. For each medication, I am going to tell you 4 things, what it is and what it is prescribed for, because I want you to understand that these are not bad medications. They are medications doing something important. The mechanism, exactly how it interacts with muscle at the cellular level. In plain language, the signal, the specific symptom pattern that suggests this medication may be the driver of your muscle loss rather than aging alone. And what to do. Not whether to stop it, what to do. One more thing before we begin. I am going to ask you to do something as you listen. Note which of these 7 applies to you. Write the number down if you need to, because at the end of this video, there is a section specifically about what happens when you are on more than one of these simultaneously. And that section matters more than any of the individual medications. Medication 1, statins, atorvastatin, rosuvastatin, simvastatin. You know these names. Most people in this demographic do, because statins are among the most widely prescribed medications in the world. Statins work by inhibiting an enzyme called HMG-CoA reductase, which is a critical step in the pathway your liver uses to produce cholesterol. Block that enzyme, LDL cholesterol falls. The cardiovascular protection is real and documented. For the right patient, statins save lives. But that same enzyme pathway, the mevalonate pathway, also produces something else, something your muscle cells cannot function without. It is called coenzyme Q10. CoQ10. CoQ10 is not optional. Your mitochondria, the energy-producing structures inside every muscle cell, use CoQ10 as a critical component of the chain reaction that produces ATP, which is the fuel that powers muscle contraction. Without adequate CoQ10, muscle cells cannot produce energy efficiently. They fatigue faster, they recover more slowly, and over time, they accumulate damage that they cannot repair at the rate a healthy cell would. Statins block the pathway that produces CoQ10 alongside the pathway that produces cholesterol. Every statin, by design. there is a second mechanism. Statins also suppress the IGF-1 signaling pathway in muscle tissue. IGF-1, insulin-like growth factor 1, is one of the primary anabolic signals that tells muscle cells to synthesize new protein. Reduce IGF-1 signaling and the muscle cell's instructions to rebuild after a workout, after a long walk, after ordinary daily activity are quieter. The muscle cell works. The signal to repair is muted. The net effect accumulates over months and years. The signal that statins may be contributing to your muscle loss is specific. Bilateral, symmetrical weakness. Both legs, both arms, roughly equal. It tends to be proximal, meaning the large muscles closest to the trunk, the thighs, the hips, the upper arms. It often worsens gradually after a dose increase, and in some patients it improves noticeably during a supervised medication holiday, which is one of the ways physicians confirm the connection. The symptom that accompanies this in many patients is fatigue disproportionate to activity, not tiredness that improves with rest. A deep cellular fatigue that does not correlate with what you have done. I want to be direct about something here. Statins protect against heart attack and stroke in patients with established cardiovascular disease or significant risk. Stopping your statin without medical guidance is not the answer. The answer is a conversation about CoQ10 supplementation alongside the statin, about whether your current dose is the minimum necessary for your cardiac protection, and about whether your muscle function is being monitored as a clinical parameter alongside your LDL. There are now 6 medications remaining on this list, and I need to tell you that for some patients watching, the issue is not one of the 7. It is the combination of several of them operating simultaneously. I will come back to that. Stay with me through the list. Medication 2, corticosteroids, prednisone, prednisolone, dexamethasone, methylprednisolone. These medications are prescribed for an enormous range of conditions: inflammatory diseases, respiratory flares, autoimmune conditions, joint inflammation, allergic reactions, and more. And they work. For the conditions they treat, corticosteroids are often remarkably effective at reducing inflammation and suppressing the immune response that is causing damage. But corticosteroids interact with muscle in 2 simultaneous and opposing ways, and the combination is what makes chronic steroid use one of the most reliably muscle-damaging medication exposures in older adults. First, they activate the ubiquitin proteasome system. That is the cellular mechanism responsible for breaking down old protein. Normally, this system operates in balance with protein synthesis. Corticosteroids push the breakdown side of that balance into overdrive. The rate at which muscle protein is degraded accelerates. Second, they suppress the anabolic signaling that drives protein synthesis. The same molecular machinery that statins affect through IGF-1 is dampened by corticosteroids through a different mechanism. Breakdown is accelerating and synthesis is slowing. Simultaneously, corticosteroids also impair insulin sensitivity in muscle tissue, which means that glucose, the fuel muscle cells use during exercise, enters them less efficiently. The muscle is being told to work while its fuel supply is being disrupted. I want to be careful here about an important distinction because I know many people watching this have had short courses of steroids, 5 days, 10 days, for a respiratory infection or a joint flare. Short-course steroid use in an otherwise healthy person is not where this concern lives. The concern is chronic use. The threshold where sarcopenia becomes clinically significant is generally continuous use at prednisone equivalent doses of 7.5 milligrams or more per day for 3 months or longer. If you have been on a daily corticosteroid for more than 3 months, your muscle mass should be a specific part of your clinical monitoring. In most cases, it is not. The signal is distinctive. The muscle loss from chronic corticosteroid use tends to be most visible in the proximal limb muscles, the thighs and upper arms, while the face and abdomen may retain or even gain mass from the fluid retention and fat redistribution that steroids cause. The result is a specific body composition pattern: thinning limbs, central weight gain, a rounded face. If you recognize that pattern in someone you know who has been on steroids for years, that combination is not aging. It is steroid-induced myopathy. Medication 3. Loop diuretics furosemide, bumetanide. You may know furosemide as Lasix. These medications are prescribed for fluid retention, heart failure, high blood pressure, and kidney conditions where excess fluid is the clinical problem. They work by blocking the reabsorption of sodium in the kidneys, which causes the body to excrete more fluid. They are effective. For the conditions they treat, loop diuretics often provide significant relief. But here is what happens every time they work. Sodium in the kidney does not travel alone. It travels with a convoy of other minerals through the renal tubule. When a loop diuretic blocks sodium reabsorption, it also reduces the reabsorption of magnesium, potassium, and calcium alongside it. Every dose, every day. Magnesium is not a mineral you can casually deplete without consequences. It is a cofactor in over 300 enzymatic reactions in the human body, including the reactions that produce ATP, the reactions that synthesize muscle protein, and the reactions that regulate the electrochemical gradient across the muscle cell membrane that makes contraction possible. Depleted magnesium and muscle do not coexist peacefully. The muscle cell trying to operate without adequate magnesium is like an engine trying to run without lubrication. The processes work, but they work inefficiently, they wear down faster, and they cannot sustain the output that health requires. Potassium depletion causes direct myopathy. This is not a theoretical risk. It is a documented clinical phenomenon with a specific lab finding: elevated creatinine kinase in the blood, which is the marker of muscle cell breakdown. Low potassium and the muscle cells begin to break down. The clinical betrayal of this situation is that loop diuretics are prescribed for heart failure and fluid conditions where muscle function is already compromised. The patient who most needs their muscle chemistry to be intact is the patient who is most systematically having it depleted day after day by the treatment for their other condition. The signal is this: nocturnal leg cramps, progressive weakness, fatigue that is worse than the clinical picture of the treated condition would predict, and an irregular heartbeat that worsens despite apparently adequate cardiac management. All of these can be electrolyte depletion. All of them should prompt a test. Medication 4. Proton pump inhibitors: omeprazole, pantoprazole, lansoprazole, esomeprazole. These are the heartburn medications, the stomach acid suppressants. The medications prescribed, often quite briefly at first, for reflux, gastric ulcers, and stomach protection in patients taking NSAIDs, and here is why this is the one that surprises people. A stomach medication has nothing to do with muscle. That is the intuition. And in the short term, that intuition is correct. But proton pump inhibitors work by dramatically reducing the production of acid in the stomach. And stomach acid is not just there to cause discomfort. It is a critical component of the digestive process that allows your body to absorb specific nutrients from food. Most relevantly for muscle, magnesium and vitamin B12. Magnesium absorption from food depends on an adequate acid environment in the small intestine. When acid production is chronically suppressed, which is what long-term PPI use does, the magnesium in your food passes through your gut increasingly unabsorbed. You are eating the right foods. The magnesium is technically present, but the door that allows it to cross into your body has been quietly closed by your reflux medication. Vitamin B12 requires a protein called intrinsic factor, which is produced by the stomach's acid-secreting cells. Those cells are suppressed by PPI therapy. Long-term PPI use reduces intrinsic factor production and impairs B12 absorption. Why does B12 matter for muscle? Because B12 is essential for myelin, the insulation around nerve fibers that allows rapid, accurate nerve conduction. And muscle strength is not just a function of muscle mass, it is a function of the nervous system's ability to recruit, coordinate, and communicate with muscle fibers. B12 deficiency causes a progressive peripheral neuropathy, a deterioration of the nerve-muscle connection that produces weakness independent of muscle mass loss. The clinical picture of long-term PPI use and muscle is this: An elderly patient who has been on a PPI for 4, 5, 6 years, far beyond the originally intended 8-week course for which these medications were approved, who is progressively weaker despite adequate protein intake, who has normal serum B12 but elevated methylmalonic acid when you run the functional test, who has muscle cramps and fatigue that nobody has connected to the medication they take for their stomach. That patient is sitting in primary care offices every day. Their PPI is renewed annually without a review of its ongoing necessity. Nobody is checking their magnesium with the right test. Nobody is running a methylmalonic acid. This is the one I said would surprise you, and this is why. Medication 5, beta blockers metoprolol, atenolol, carvedilol, bisoprolol. Beta blockers are prescribed for heart failure, hypertension, arrhythmia, angina, and after heart attack. For many patients with established cardiovascular disease, they are a cornerstone of management. Their mechanism relevant to muscle is different from the 4 we have discussed. Beta blockers do not deplete nutrients. They do not accelerate breakdown. What they do is pharmacologically limit the capacity for muscle to respond to exercise. Skeletal muscle contains beta-2 adrenergic receptors, the same receptor family that beta blockers target in the heart. When a beta blocker occupies these receptors in muscle tissue, it reduces the muscle's capacity to hypertrophy, to grow and strengthen in response to the exercise stimulus. The person exercising on a beta blocker receives a blunted anabolic response to the same training load compared to a person without the medication. Beta blockers also cap maximum heart rate. In practical terms, this means that the cardiovascular intensity an older adult can achieve during exercise is pharmacologically limited, and cardiovascular intensity drives a significant portion of the hormonal and metabolic responses that support muscle maintenance, including growth hormone release, which happens primarily during high-intensity exertion and during deep sleep. Beta blockers also reduce growth hormone secretion overnight, which is when the majority of muscle repair occurs. The signal for beta blocker contribution to muscle decline is specific. It is not weakness at rest. It is the person who is exercising, who is walking, who is doing what they were told to do, and who is not responding, whose strength is not improving, whose exercise tolerance is not increasing, whose body seems to have stopped adapting to the training it is receiving. This is not a reason to stop a beta blocker. For many patients, it is a non-negotiable cardiac medication. What it is a reason to adapt the exercise prescription. Heart rate as the intensity metric becomes invalid on a beta blocker. Rate of perceived exertion, how hard the exercise feels, is the appropriate guide. Higher volume at submaximal intensity rather than higher intensity is the compensation strategy. Your exercise physiotherapist or cardiac rehabilitation team needs to know you are on a beta blocker in order to calibrate your program correctly. In many cases, they are not told. Or they are told and nobody explains the implications to you. Medication 6. Fluoroquinolone antibiotics, ciprofloxacin, levofloxacin, moxifloxacin. These are broad-spectrum antibiotics used for respiratory infections, urinary tract infections, and other bacterial conditions. They are effective, they are widely prescribed, and they carry an FDA black box warning for tendon damage and peripheral neuropathy that most patients are never shown. The mechanism by which fluoroquinolones damage muscle and connective tissue is distinct from every medication on this list. Fluoroquinolones inhibit an enzyme called DNA-gerase, which is how they kill bacteria. They block bacterial DNA replication. The problem is that a version of this enzyme exists in human mitochondria. In older adults whose mitochondrial reserve is already reduced by age, a course of fluoroquinolones can impair mitochondrial DNA replication in muscle cells and tendons. The tendon damage, most commonly in the Achilles, is well documented. Less discussed is the broader pattern of muscle weakness and fatigue that can follow a fluoroquinolone course in susceptible individuals. What makes this medication particularly insidious in this context is the timing. The damage often does not present immediately. Fluoroquinolone toxicity can manifest weeks after the final dose, at a point where the connection to the antibiotic is no longer obvious. A patient who completed a 10-day course of ciprofloxacin and notices new muscle weakness 6 weeks later does not spontaneously connect those two events. Their doctor, seeing them 6 weeks after the course ended, does not spontaneously connect them either. The signal is a new pattern of muscle weakness, tendon pain, or peripheral tingling that begins in the weeks following a fluoroquinolone course. The Achilles tendon is a specific red flag. Any new or worsening Achilles pain after a fluoroquinolone course should be evaluated promptly because fluoroquinolone-associated tendon rupture is a real clinical event that can be avoided with early identification. For future infections, fluoroquinolones are not always the necessary choice. In many cases, other antibiotic classes are equally effective. If you have had a reaction to fluoroquinolones, that belongs in your medical record so that it informs future prescribing decisions. Medication 7. Amiodarone and certain antiarrhythmic agents. Amiodarone is prescribed for serious cardiac arrhythmias. It is an effective medication for a condition that can be life-threatening if untreated, and it has one of the most complex side effect profiles of any commonly used medication in cardiovascular medicine. The mechanism relevant to muscle is indirect but significant. Amiodarone contains iodine and interferes with thyroid hormone metabolism, specifically with the conversion of T4, the inactive form of thyroid hormone, to T3, the active form. This creates what functions as a pharmacologically induced hypothyroid state in many patients, even when their TSH appears within the normal laboratory range. Thyroid hormone is a primary regulator of muscle protein synthesis. It governs the rate at which muscle cells produce protein, the rate at which they break down old protein, and the metabolic activity of the entire system. When T3 is functionally low, whether from true hypothyroidism or from amiodarone-induced conversion impairment, muscle mass declines, strength declines, and the energy available to the muscle cell is reduced. The specific problem with amiodarone is that standard thyroid monitoring may miss this effect. TSH can remain normal while free, T3 is low, and the functional consequence is operating. The patient is told their thyroid is fine. The muscle continues to lose mass. Nobody connects the antiarrhythmic to the weakness because the test everyone is looking at says everything is in range. The signal is progressive weakness in a patient on amiodarone, accompanied by fatigue, cold intolerance, and sluggishness, the classic hypothyroid symptom constellation. In someone whose TSH is normal but whose clinical picture does not fit that normal result. Free T3 is the test that matters here, and it is frequently not ordered. I want to stop here for a moment. Not one of these 7 medications was prescribed carelessly. Not one of these physicians made an error. Every prescription on this list was written in good faith by someone trying to protect a patient from something serious. The statins protect against heart attack. The steroids control inflammation that would otherwise cause severe damage. The diuretics prevent the fluid accumulation that strains a failing heart. The PP is protect against ulcers and reflux that significantly reduce quality of life. The beta blockers are holding a rhythm that without them would be dangerously unstable. The antibiotics treated infections that could have become systemic. The amiodarone is suppressing arrhythmias that could cause cardiac arrest. Every single one of those reasons is real. What is also real is that the follow-up conversation, the one about what these medications do to muscle over months and years, and what can be done to protect against that effect while keeping the medication, almost never happens. Not because physicians do not care, because there is no appointment scheduled for it, because the system has not built one. That gap is not acceptable. And closing that gap for you is exactly what this video is for. Arthur was on 3 of the 7. A statin, a loop diuretic, and a proton pump inhibitor that had been prescribed 4 years earlier for reflux and had never been reviewed since. 3 medications, each individually presenting a modest muscle risk. Together, they were doing something that no single prescriber had modeled, depleting CoQ10, magnesium, and B12 simultaneously while blunting the anabolic signaling that would normally compensate for some of the age-related muscle loss he was experiencing. His cardiologist managed his statin and his diuretic. His GP managed his PPI. Neither of them had looked at his muscle function as a clinical parameter, and none of them had looked at all three medications as a system. This is the part I need you to write down, or replay, or share with the person who should hear it. The clinical reality. Being on 2 or more of these 7 medications simultaneously does not mean your risk doubles. It means the multiple depletion and suppression mechanisms are operating in parallel against the same muscle tissue at the same time, while nobody who is managing any one of those medications is seeing the combined picture. A statin depletes CoQ10, a loop diuretic depletes magnesium, a PPI depletes magnesium and B12. In a patient taking all three, every pathway that muscle protein synthesis depends on is simultaneously compromised. The muscle is not receiving the medication's side effects one at a time, it is receiving them all at once. This is not rare. This is the reality of polypharmacy in older adults, and it is one of the most under-recognized drivers of functional decline in this demographic. How many of the 7 are you on? Hold that number in mind as we move to what to do about it. Before I give you the words to use with your doctor, I want to give you a self-assessment you can do right now. The 30-second chair stand test. You need a straight-backed chair without armrests or a chair with armrests that you will not use. Sit in the middle of the seat, feet flat on the floor, arms crossed over your chest. Set a timer for 30 seconds. On start, stand fully upright and sit back down, as many times as you can in 30 seconds. Write your number down. For women between 60 and 64, 12 or more is normal. Below 10 warrants evaluation. For women between 65 and 69, 11 or more. Below 9. For women between 70 and 74, 10 or more. Below 8. For women 75 and over, 8 or more. Below 6 is a significant finding. For men between 60 and 64, 14 or more is normal. Below 12 warrants evaluation. For men between 65 and 69, 12 or more. Below 10. For men between 70 and 74, 12 or more. Below 10. For men 75 and over, 10 or more. Below 8 is a significant finding. If you are below the threshold for your age and sex, that is not a diagnosis. It is a signal that lower extremity muscle function warrants formal clinical assessment. Bring that number to your next appointment. The blood tests that tell you whether a medication is the driver are specific. I want to give them to you by name. Creatinine kinase, or CK. This is the marker of muscle cell breakdown. An elevated CK in a statin user or following a fluoroquinolone course is a documented laboratory correlate of drug-induced muscle damage, RBC magnesium, not serum magnesium. Standard panels check serum magnesium, which can appear normal while intracellular magnesium is significantly depleted. Anyone on a loop or thiazide diuretic or on a long-term PPI should have this test rather than the standard one. Methylmalonic acid, or MMA. This is the functional B12 test. Serum B12 can read as normal in early deficiency because B12 binds to transport proteins in the blood even when it is not functioning adequately at the cellular level. MMA rises when functional B12 deficiency is present. Anyone on a PPI for more than 12 months should have this test. CoQ10 level. Not universally available, but worth requesting for anyone on a statin for more than 2 years who has fatigue and muscle symptoms disproportionate to their age and activity. Free T3, not just TSH. For anyone on amiodarone whose clinical picture includes weakness and fatigue with a normal TSH, and hand grip dynamometry. Ask for it by that name. It is a validated 30-second test of whole body muscle function. A 2015 Lancet study of 140,000 people across 17 countries found that grip strength was more predictive of cardiovascular mortality than systolic blood pressure. It is not routinely done. It should be. I am going to give you the exact words now. Not a general suggestion that you talk to your doctor. The specific sentences that open a specific conversation. One that begins with what you have learned here and ends with a clinical plan that accounts for your muscle function alongside your other conditions. Arthur used a version of these words, and the conversation that followed changed his management in ways that 2 years of routine appointments had not. Write this down, or replay this section, or share the timestamp with the person who needs to hear it. Your exact words at your next appointment. Now let me bring this back to Arthur. His CK was mildly elevated. Not dramatically, not in the range that would have triggered concern on a standard panel without context, but elevated in the specific pattern consistent with statin myopathy. His RBC magnesium was below range. 3 years of serum magnesium readings had been normal. His methylmalonic acid was elevated. His serum B12 had been in the normal range for 4 years. 3 tests, all of them standard lab procedures, none of them ordered until the right question was asked. His cardiologist reduced his statin from 40 milligrams to 20 and added CoQ10. His GP added magnesium supplementation and monitored his potassium closely given the diuretic. His PPI was reviewed and tapered over 6 weeks under supervision. His chair stand test at baseline, 9 stands, below the threshold for a man his age. At 12 weeks, 13. At 6 months, his wife stopped watching him walk across the kitchen with that look on her face. He stopped reaching for the counter. He carried the groceries from the car to the kitchen in one trip. He sat across from me at his 6-month follow-up and said something I have thought about since. He said, "I spent 2 years believing my body was doing what 71-year-old bodies do. And it was, but it was also doing something else, and nobody told me those were different things until you did. This is what this channel does. Your cardiologist gets 12 minutes, your GP gets 15. Your pharmacist is focused on interactions, not on what the combined picture is doing to your muscle function over years. This video just gave you what those appointments could not give you alone. You now know the 7. You know what each one does at the molecular level to the tissue that carries you through your day. You know the tests to request by name. You know the language that turns this from a private worry into a clinical conversation. I have one question before you go. How many of the 7 are you on? Not your medical history, just the number. Put it in the comments. Because I have a strong suspicion about what the distribution looks like among the people watching this channel, and I want to show you something about how common this overlap actually is. Your number matters, and when you write it, someone else reading it tonight is going to feel seen for the first time. If this gave you something your last appointment did not, subscribe. Free. First link below. When you write to me, I write back.